What's the primary monitoring requirement for a patient starting a course of terbinafine tablets for onychomycosis? Yes, liver function test. Okay, liver function test is used. What's onychomycosis? What condition is this? What condition is this? Anyone? Yes, so this is fungal nail infection. Okay, onychomycosis is nail infection, fungal nail infection. All right. So can you treat fungal nail infection over the counter or not? Can it be treated over the counter? And when do you refer patients? Okay, so it can be treated over the counter with amorolfine, right? So when do you refer patients for fungal nail infection? What are the reasons to refer patients? Okay, if they are diabetic, okay, if more than two nails are affected. So if more than two nails are affected, then the patient should be referred. If the patient is diabetic, then the patient should be referred. Okay, what's the age licensing for amorolfine? What's the age licensing for amorolfine? The nail lacquer. What's the age licensing? From what age can it be used? Yeah, so Rainbow said 18, so age 18, okay? From 18 years. So anyone below the 18, then you can't treat over the counter. All right, so 18 years and above. Okay. So patients who are diabetic with nail infection should be referred. If more than two nails are affected, then they should be referred as well. Okay, so terbinafine is an antifungal tablet used for nail infection and requires liver function monitoring because it could be toxic to the liver. All right, so next question. A mother brings her child into the pharmacy who has had persistent diarrhea for 2 days. Which symptom, if reported, is the most urgent red flag requiring immediate medical referral? Which symptom, if reported, is the most urgent red flag requiring immediate medical referral? Yes, option C is correct. Okay, so remember that if you get a question in the exam, one of the red flags for referral in children is um, anuria. Okay, so and even in practice, one of the questions you should always ask is if the patients has still got wet nappies. Okay, reduced urine output is a red flag for referral. So these patients, for this question, if the child has not passed urine in the last 12 hours, that is a red flag for referral. So what are the other symptoms that could require referral in children? What are the other symptoms to look out for that could require referral in children? Cyanosis, okay, lethargic. What kind of rash would require referral in children? What kind of rash would require referral in children? Immediate referral. Stiff neck, yeah, so non-blanching rash. So if the rash is non-blanching, okay, so a rash that does not fade away when a glass is pressed firmly against it. If it's non-blanching, then it could indicate meningitis and you will need to refer. Okay, if it's non-blanching, then you will need to refer. So also fever might also be a red flag for referral as well. Okay, if a child has got fever of greater than 3 months and the child is under 3 months, fever of greater than 38 degrees Celsius, and the child is under 3 months, then the child if it's over 48 hours, and the child should be referred. Okay. So we talked about non-blanching rash for meningitis. What are the treatment strategies? What medications are used for treating meningitis? What medications are used for treating meningitis? What are the antibiotic options for meningitis? Okay, so Moni said benzyl penicillin. Okay, what else? Aisha said penicillin G. That's one option. What are the other treatment options? So benzyl penicillin is used for treating meningitis before transfer to hospital. Okay, so when the patient gets to hospital, ceftriaxone, cefotaxime, and chloramphenicol. Okay, chloramphenicol is suitable if the patient has got allergies to penicillin. Okay, so benzyl penicillin, ceftriaxone, cefotaxime, and chloramphenicol are treatment options for meningitis. And we said symptoms are non-blanching rash. If the patient has got stiff neck, photosensitivity, sensitivity to light, those are symptoms of meningitis in children. All right, so next question. Which key counseling points must be given to a patient about taking the oral anticoagulant rivaroxaban? What's the key counseling points? A, B, C, or D? Yes, option B is correct. So remember that 15 and 20 milligram must be taken with food. Okay, 15 and 20 milligram must be taken with food. Don't forget that. Which DUAC should not be kept in a dosage box? And which one causes dyspepsia? Which DUAC causes dyspepsia and should also not be kept in a dosage box? Dabigatran, yeah. So D for dabigatran, D for don't keep in a dosage box, and D for can cause dyspepsia. A patient receiving palliative care is prescribed a number of regular medications, including a statin. What is the usual recommendation regarding continuing the statin therapy in the last months of life? A. Continue the statin as it offers significant cardiac protection. B. Continue the statin to maintain established routines. C. Stop the statin. And D. Reduce the statin dose by half to reduce side effects. So remember that palliative care, one of the medications that should be stopped during palliative care is statins, okay? One of the medications that should be stopped during palliative care is statins. Now, quick recap on statins. What medications have capped dose of 20 milligram with statins? Which ones? What medications do you have to cap the dose to 20 milligram? Okay. Aisha said calcium channel blockers. That's correct. So medications like verapamil, medications like amlodipine, diltiazem. With these medications, you need to cap the dose of statin to 20 milligram. I've got amiodarone and I've got verapamil. Okay. So CCBs, amiodarone, and ranolazine. With these three medications, you need to cap the dose of statin to 20 milligram. What about fibrates? Do fibrates interact with statins? Do fibrates interact with statins? If you are here on this chat, please type get active so we can all get ourselves prepared. Yes, so with fibrates, the capped dose is 10 milligram. With calcium channel blockers, with amiodarone and ranolazine, the capped dose is 20 milligram. However, with fibrates, the capped dose is 10 milligram. Okay. Statins should be stopped before pregnancy. How many months do we need to stop statins before pregnancy? So there are so many medications that could be stopped in palliative care. Statins are usually the common ones to ask, okay? But antihypertensives sometimes should be stopped, okay? Antihypertensives could be stopped. Aspirin is used for, if it's used for prevention, sometimes you might need to weigh the benefits and the risk of using the medication. Okay, even diabetes medications may need to be stopped as well in palliative care, but statins are the really common ones. So yeah, statins should be stopped 3 months before pregnancy. Okay, statins should be stopped 3 months before pregnancy. What about methotrexate? Methotrexate should be stopped how many months before pregnancy? So methotrexate, there's a different timeline for male and for female. Okay, for females, how many months, and for males, how many months? So Aisha said 6 months for women and 3 months for men. Okay, so statins should be stopped 3 months. Okay, so during treatments, females of childbearing potential should use effective contraception during treatment and for at least 3 months for methotrexate, while male patients should use effective contraception during treatment and for at least 3 months after last treatment. So 3 months for statins, for methotrexate, 6 months for females, and 3 months for males. Okay, what about mycophenolates? Mycophenolates, what's the timeline for mycophenolates? What's the timeline for mycophenolates for conception? Yes. Okay. So Aisha said 6 weeks for women and 90 days for men. So mycophenolate 6 weeks for women, 90 days for men. Methotrexate 6 months for men, 3 months for females. Okay. And for statins, 3 months. Okay. So with statins, patients might need to measure their creatine kinase. Okay. From what level do we consider withdrawing the statin? What's creatine kinase level do we consider withdrawing the statin? The creatinine kinase rises to how much of the upper limit of normal? So 5 times the upper limit of normal. Thank you, Hasha. 5 times upper limit of normal for creatine kinase, and 3 times upper limit of normal for liver function test. So remember, with statins, you measure the liver function, you measure the creatine kinase. For patients who are at high risk of diabetes, you measure the HbA1c. Okay, you also measure the thyroid function, because hypothyroidism can predispose a patient's risk of side effects with statins. So I've mentioned thyroid function, I've mentioned creatine kinase, I've mentioned liver function, I've mentioned HbA1c. For statins, you also need to monitor the full lipid profile to see how the patient is responding. Okay, and we said for high intensity statin, how much reduction in cholesterol are we expecting to see? How much reduction in cholesterol are we expecting to see with high intensity statins? Yes, thank you, GMAT. Okay, 40% reduction, 40% reduction in high intensity statins. And remember that your high intensity statins are your atorvastatin 80 milligram, okay, and atorvastatin 20 milligram as well, and rosuvastatin as well is also high intensity. If you get a question for primary prevention, remember that 20 milligram of atorvastatin is for primary prevention, and primary prevention are for patients who have a Q risk score of greater than 10%. So if the Q risk score is greater than 10%, then the patient qualifies for um, primary prevention with statins. Okay. Do we use aspirin for primary prevention? Aspirin can be used for primary prevention. Is that true or false? So we don't use aspirin for primary prevention. We only use statin, atorvastatin 20 milligram. Okay. And if it's secondary prevention, if the patient has had an established cardiovascular disease already, then we need to give 80 milligram of atorvastatin. That's what is recommended by NICE. So 80 milligram of atorvastatin for secondary prevention and 20 milligram of atorvastatin for primary prevention. A patient is starting methotrexate for rheumatoid arthritis. They currently have an infection and the GP has prescribed trimethoprim. What is the immediate pharmaceutical action? A, B, C, or D? What is the immediate action for if you receive a prescription for trimethoprim and the patient is on methotrexate? Yeah. So there's increased risk of bone marrow suppression if methotrexate and trimethoprim are used together because these two medications are antifolates. Okay. So aside this bone marrow suppression interaction, what are the other possible results of using methotrexate and trimethoprim together? What are the other possible results of using methotrexate and trimethoprim together? What organ toxicity are we going to see with methotrexate and trimethoprim? What organ toxicity are we going to see with methotrexate and trimethoprim? It's actually renal toxicity. Okay, renal toxicity, nephrotoxicity with methotrexate and trimethoprim. So if you go to your BNF and you look at the interaction between methotrexate and trimethoprim, both could lead to nephrotoxicity. Okay. Yeah, so both methotrexate and trimethoprim can increase the risk of nephrotoxicity, and both methotrexate and trimethoprim can increase the risk of hematological side effects. So between methotrexate and trimethoprim, which of them will cause increased potassium levels, increased serum potassium between trimethoprim and methotrexate? Which causes increased serum potassium? Between methotrexate and trimethoprim. Yes, thank you, Noe. Thank you, Aisha. Thank you, Tochi. Trimethoprim causes hyperkalemia. Okay, so let's quickly revise. What other medications cause hyperkalemia aside trimethoprim? Examples of medications that will cause hyperkalemia. Which anticoagulant causes hyperkalemia? Okay, so Jimata said thanks B. So ACEIs is one of them. Trimethoprim is one of them. Heparins, thank you. Heparins can cause hyperkalemia. Okay, heparins can cause increased potassium level. What else? These are the really common ones: heparin, trimethoprim, ACEIs, and ARB. So aside ACEIs and ARB, which other medication used for heart failure can cause hyperkalemia? Aside ACEIs and ARB, which other medication used for heart failure can cause hyperkalemia? So Mola said potassium sparing diuretics. Thank you. What are examples of potassium sparing diuretics? That's your spironolactone and your eplerenone. Okay, they can cause hyperkalemia. So spironolactone, eplerenone. There's still another medication used for heart failure that can also cause hyperkalemia. Which one is it? Which other medication for heart failure can cause hyperkalemia? It belongs to a similar class with ACEIs and ARBs. Which one is it? It's an ARNI. Yes, it's an ARNI. Yes, the generic name is sacubitril and valsartan. Sacubitril and valsartan can cause hyperkalemia. Okay. Yes, sacubitril and valsartan can cause hyperkalemia. So we've learned Medications that cause hyperkalemia. Mnemonic is TENS B, T for trimethoprim, H for heparin, A for ACEIs, ARBs or ARNIs, K for potassium sparing diuretics like spironolactone and eplerenone, and B for beta blockers. And what are the symptoms to expect with hyperkalemia? What are the symptoms to expect with hyperkalemia? So symptoms to expect with hyperkalemia. Palpitations, yes, palpitations, ECG changes. Okay, palpitations, ECG changes. And when the potassium level is so high and it affects the heart, what medication can we use? What medication can be used for treatment? So symptoms of hyperkalemia, we said it could cause palpitations, it could cause ECG changes, okay? What medication can we use for treatments when it affects the heart? Okay, so Tochi said calcium gluconate. It's actually calcium gluconate, okay? Calcium gluconate can be used for management of ECG changes due to potassium levels, okay? Calcium gluconate can be used for management of ECG changes due to potassium levels. So if you get a question like that, IV calcium gluconate is a preferred option for treatment. What are the other medications used for management of hyperkalemia? Yes, Asha has given us a yes. So salbutamol insulin as well can be used for management of hyperkalemia. Okay. So now that we're discussing electrolyte, I'll just mention a few drugs and you're going to tell me what electrolyte disturbance that is associated with that drug. Okay. So the next one on my list is bisphosphonates. What are you going to expect with bisphosphonates? Is it hypocalcemia or hypercalcemia? What are you going to expect with bisphosphonates? Is it hypocalcemia or hypercalcemia? And what are the symptoms of hypocalcemia? So with bisphosphonates like alendronic acid and risedronic acid will cause hypocalcemia. And what are the symptoms of hypocalcemia? Symptoms of hypocalcemia: bone pain, tingling sensation, numbness, okay, muscle weakness. Those are symptoms of hypocalcemia. Medications like thiazide diuretics would cause hyperkalemia. Is that true or false? Thiazide diuretics would cause hyperkalemia. Is that true or false? Thiazide diuretics will cause hyperkalemia. Is that true or false? Yes, thiazide diuretics will cause hypokalemia. Thiazide diuretics will cause hypomagnesemia as well. Thiazide diuretics will cause hyponatremia. Okay, so with your thiazide diuretics, it's going to cause hypokalemia, hypomagnesemia, hyponatremia, but hypercalcemia. So don't forget that. So most of your diuretics will cause low electrolytes. Okay, low electrolytes. For calcium, it's going to be high, but for potassium and sodium, it's going to be low. So if a patient presents with vomiting, coma, convulsions, nausea, and vomiting, what what electrolyte disturbance could that be caused by? Nausea, vomiting, convulsions. In severe cases, seizures as well. What electrolyte disturbance could that be caused by? Okay, so Aisha said hyponatremia. Okay, Hasha said hyponatremia. Yes, so that's correct. Hyponatremia can cause nausea, can cause, remember the three C's, the three C's of hyponatremia: nausea, vomiting, convulsions, coma, confusion as well. Confusions, convulsions, and coma. In severe cases of hyponatremia, those are the symptoms to expect. Okay? Carbamazepine will cause hypernatremia. Is that true or false? Carbamazepine will cause hypernatremia. Is that true or false? Yes, that's false. Carbamazepine will cause hyponatremia. Okay, well done, everyone. So this is the next question on my screen. When counseling a patient on the correct use of a steroid spacer device for their asthma treatment, what is the best advice regarding cleaning? A, B, C, or D? So when cleaning spacer device, you're not allowed to rub. Okay, so we should just clean it with mild detergents and allow to air dry. And that's because we want to reduce the risk of electrostatic. Okay, always allow to air dry. So how often should spacer devices be cleaned? And how often should spacer devices be replaced? In terms of care and management of spacer devices, how often should spacer devices be cleaned? And how often should spacer devices be replaced? How often should spacer devices be cleaned, and how often should spacer devices be replaced? So replace every 6 to 12 months, and it should be cleaned monthly. Okay, it should be replaced every 6 to 12 months, and it should be cleaned monthly. Okay, what kind of inhalers are spacer devices used with? Is it your dry powder inhaler or your method dose inhalers? Are spacer devices used with dry powder inhalers or method dose inhalers? Yes, spacer devices are used with methadone inhalers. And in terms of differences between your MDIs and DPIs, okay, spacer devices are used with your methadose inhalers. So how should methadose inhalers be used? Should it be used, should patients inhale deeply or not? Should they inhale quickly and deeply or slowly and deeply? Now I'm talking about methadose inhalers. Is it slowly or is it fast? So it's slowly, okay? So patients should inhale slowly. Unlike the dry powder inhalers, with dry powder, it's in powdered form. So they need to inhale fast to prevent loss of the medication, okay? But for method dose inhaler, it should be inhaled slowly and deeply, okay? Slowly and deeply for method dose inhalers. And your method dose inhalers are the ones that can be used with a spacer device. Okay, using spacer device with metered dose inhaler helps to ensure that more drug gets to the lung. And what's the other advantage? What's the advantage of using a spacer device with a metered dose inhaler? What's the advantage of using a spacer device with a metered dose inhaler? Anyone? Yes, thank you, Jim. As it reduces the risk of oral thrush. Okay, so patients on steroid inhalers would benefit from using a spacer device because it reduces their risk of oral thrush. So what have we learned about spacers? We've learned that it should be replaced every 6 to 12 months. It should be cleaned once a month by washing with a mild detergent and allowed to air dry. Okay, and spacer devices are used with MDIs should be used by inhaling slowly and deeply, unlike dry powder inhalers which patients would need to inhale quickly. Okay, then what's the MHRA advice regarding PMDIs? Does anyone know what the MHRA advice regarding PMDIs is? What's the MHRA advice? So basically, the MHRA has received reports of patients who have inhaled objects into the back of their throats. Okay, so patients should be reminded to remove the mouthpiece cover fully, shake the inhaler device, and check that the mouthpiece is clear before inhaling. Okay, so that's one thing you need to remember as well. MHRA advice is risk of airway obstruction from aspiration of loose objects. So patients should be reminded to check that there is no obstruction. You should remove the mouthpiece cover fully, shake the inhaler device, and check that it's clear before inhaling any dose. The patient has issued a private prescription for a non-CD medication. How long must the pharmacy retain this prescription after the dates of the supply? Private prescription should be retained for 2 years. Okay, private prescription should be retained for 2 years. So if this was a CD medication, what would be the fate of the prescription if this was a private prescription for, say, oxycodone or morphine? If this was a private prescription for, say, oxycodone or morphine, how long would the prescription be retained for? Or what would be the fate of the prescription? So for private CD prescriptions, what's the fate of private CD prescriptions? It should be sent off to NHS BSA, okay? Remember that your private CD prescription should be sent off to NHS BSA while a copy should be retained. So make a copy and keep in the pharmacy for 2 years, but the original prescription should be sent to NHS BSA. Original prescription of private prescriptions should be sent to NHS BSA. What forms are used for private CD prescriptions? What forms are used for private CD prescriptions? What's the name of the form? What's it called? Yes, it's the PCD prescription. It's pink in color. It's different from the normal FP10 prescription. Okay, so private CD prescriptions are should be on an authorized form, not just any prescription form, not just any private prescription. It should be on an FP10 PCD prescription. The original prescription should be sent off to NHS BSA, while a copy should be kept in the pharmacy for 2 years. Okay, how long are CD records needed to be kept for? CD records should be kept for how many years? CD records should be kept for how many years? Yes, 2 years from the last entry date. Okay, CD records should be kept for 2 years. Okay, 2 years from the date of last entry. That's correct. Well done. What about RP records? How long should RP records be kept for? 5 years. Well done, Gloria. Well done, Hasha. Well done, GMAT. So RP records should be kept for 5 years. Um, Private prescription records should, however, be kept for 2 years. CD prescriptions, okay? CD registers, CD records should be kept for 2 years as well. How long should specials be kept for? Records of specials. How long should records of specials be kept for? Vet prescription should also be kept for 5 years. Okay, so RP records should be kept for 5 years. Vet prescriptions should be kept for 5 years. Specials should also be kept for 5 years. So minimum retention period for vet prescriptions is 5 years. RP records is 5 years. Specials is 5 years. Controlled drugs records is 2 years from the date of last entry. Okay, CD records should be kept for 2 years from the date of last entry, and private prescription records should also be kept for 2 years. I hope that's clear. A patient with type 2 diabetes has successfully titrated their insulin dose, but recent blood sugars show persistent hypoglycemia overnight. Which adjustment is most likely necessary? Or let's change this from overnight and let's change this to in the morning. So the morning sugar level is high or is low, hypoglycemia in the morning. Yes, vet prescriptions should be kept for 5 years. Yeah, so if the blood sugar level in the morning is low, okay, if the patient has hypoglycemia in the morning, then we need to adjust the basal insulin, which is the nighttime insulin. Okay, so nighttime insulin should be adjusted. Okay, nighttime insulin should be adjusted, and we're going to reduce the nighttime insulin because the patient has hypoglycemia. Okay, so because the patient has hypoglycemia in the morning, then we're going to reduce the nighttime insulin. Okay, what about if the patient has hypoglycemia after meals, or rather hyperglycemia after meals? Which insulin are we going to work on? Is it the basal or the bolus insulin? If the patient has hyperglycemia after meals, we're going to work on the bolus insulin. Now, is it going to be increased or reduced if it's hyper? If it's hyper, we're going to increase. Yes, thanks guys. So if the insulin after meals is high, we're going to increase the bolus dose. Okay, so that's just the way to understand it. The bolus insulin is what affects the postprandial glucose. Okay, however, the basal insulin is what is going to affect the blood sugar in the morning. So this patient, for example, that has hypoglycemia Let's assume the patient has hypoglycemia overnight and in the morning, then we are going to adjust the basal insulin. Make sure you try and learn this before your exams because it can come out. All right, while we are still here, we've got long-acting insulins and we've got short-acting insulin. So insulin degludec, is it short or long-acting? Insulin degludec, is it short or long-acting? Insulin degludec is long-acting, okay? So in terms of management of type 1 diabetes, there are three insulin regimens. We've got basal bolus insulin regimen. We've got the pre-mixed one, the biphasic one, pre-mixed or the biphasic insulin regimen, and we got the insulin pump. Okay, so which regimen is first line for patients with type 1 diabetes? Is it basal bolus or is it the biphasic insulin regimen? What's the first line for patients with type 1 diabetes? What insulin regimen is first line for patients with type 1? Yes, thank you, Aisha. Basal bolus is first line for patients with type 1 diabetes. Okay, basal bolus is first line for patients with type 1 diabetes. What's first line for gestational diabetes? What insulin type is first line for gestational diabetes? So the patient has hypoglycemia in the morning, you reduce the dose, okay? Because it means that we're giving the patient too much insulin. That's why the blood sugar is becoming low in the morning. So if the patient has hypoglycemia in the morning, then we are going to reduce the nighttime dose of the basal insulin. Yeah, so isoflurane insulin is first line. Thank you, Asha. Isoflurane insulin is first line for gestational diabetes. Okay. From what sugar level do we say that we need to give patients insulin immediately? Gestational diabetes. For patients with for pregnant women, from what glucose level do we give patients insulin immediately? Yes, 7. So women who have a fasting plasma glucose of 7 and above 7, should be treated with insulin immediately. So greater than 7, then your treatment option is with insulin. What about if it's less than 7? What's first line for gestational diabetes? If the fasting plasma glucose is below 7, what's first line? What's first line if the plasma glucose is below 7? Metformin, yeah. So metformin is first line if the plasma glucose is below 7. Obviously, that's after diet and exercise has been tried. Okay, so diet and exercise should be tried first and then metformin first line. For women with plasma glucose above 7, then first line is insulin. And we said isoflurane insulin is the preferred option. Okay, so remember for hypoglycemia, if you get a question in the exam and the patient comes into the pharmacy and you notice that the patient is anxious, the patient has tremor, and patient is visibly sweaty, what comes to mind? What comes to mind if you see if the patient is experiencing tremor, the patient is visibly sweating, the patient is shaking, what comes to mind? Hypoglycemia. Okay, hypoglycemia. Those are symptoms of hypoglycemia. And what are you going to treat with? Are you going to treat with glucagon? What are you going to treat with? Yeah, so we're going to treat with sugar, okay? Fast acting sugar. So it could be 3 to 14 spoons of sugar. It could be juice, okay? 150 to 300 ml of juice. It could be dextrose tablets, okay? But it has to be fast acting sugar, not biscuits, okay? It has to be fast acting sugar. And glucagon is only given when the patient is unconscious. Okay, if the patient is unconscious, then IM glucagon is a preferred option. A patient on empagliflozin calls to the pharmacy that they have had severe vomiting and diarrhea for 18 hours. What is the most important advice? What's the most important advice for a patient who has had severe vomiting and diarrhea for 18 hours? A, B, C, or D? Remember that there are medications that we need to stop if the patient is having an episode of diarrhea and vomiting, and that's where our sick day rules come into play. So don't forget sick day rules, SADMAN drugs. Okay, SGLT2 inhibitors is one of them. We've also got ACEI inhibitors or ARBs. We've also got diuretics. We've also got NSAIDs. We've also got metformin. Okay, SADMAN. So with these drugs, the patient needs to stop them if they experience vomiting and diarrhea. Okay. However, for insulin, the patients need to stop their insulin if they are sick. Is that an appropriate advice for patients to stop their insulin if they experience severe vomiting and diarrhea? Now I'm asking about sick day rules in patients who have got diabetes. No, okay. So instead, what do we tell patients to do? Patients should not stop their insulin. What do we tell them to do instead? They need to keep eating and drinking. Okay. Do they need to increase their frequency of insulin monitoring or reduce the frequency of insulin monitoring? For patients on insulin, do they need to increase? Yes, they need to monitor their insulin more frequently. Okay. Monitor insulin more frequently and monitor ketones as well every 2 hours. So increase monitoring. Okay. Do not stop insulin, but increase monitoring of blood sugar and ketone level. And they need to stay hydrated. Okay, they need to stay hydrated as well. They need to keep eating and drinking throughout the period. A mother brings her 3-year-old child to the pharmacy presenting with red sticky eye with post discharge, making the eyelids hard to open. Which condition is most likely? Yes, they might need to increase insulin dosage, but it all depends on what their readings are. So you don't just outrightly tell patients to increase or decrease their insulin. Instead, you tell them to monitor their insulin levels more frequently. So this is a case of bacterial conjunctivitis. Well done, Jimat and Aisha. So with bacterial conjunctivitis, sticky eyes, discharge, the eyes are stuck together. Okay, this is a symptom of bacterial conjunctivitis, and we can treat bacterial conjunctivitis in children from 2 years and above. Everyone 2 years and above can be treated over the counter with chloramphenicol eye drop. Okay, so with allergic conjunctivitis, how would you know it's allergic? What are the symptoms of allergic conjunctivitis? Watery discharge, itchy eyes, redness of the eyes. The eyes could even be swollen. Okay, swollen eyes, itchy eyes, redness of the eyes. That could be allergic conjunctivitis. How will you differentiate between viral conjunctivitis and allergic conjunctivitis? How would you differentiate between viral conjunctivitis and allergic conjunctivitis? Which one occurs in one eye? Yeah, viral conjunctivitis usually starts in one eye. Okay, viral conjunctivitis usually starts in one eye. And with viral conjunctivitis, it's self-limiting. Um, no need to treat, just encourage eyelid hygiene and all of that. Okay. So generally, with regards to eye, if the patient has pain in the eye, visual loss, phototoxicity, photosensitivity, those are reasons to refer patients. Okay, but generally, it can be treated over the counter if the patient does not have any red flag. With bacterial conjunctivitis, we said chloramphenicol eye drops. With allergic conjunctivitis, they can use an OTC antihistamine. What's the other medication that can be given for allergic conjunctivitis? What other medication can be given for allergic conjunctivitis aside OTC antihistamines? Sodium chromoglycates, yes, thank you, Angel. So sodium chromoglycates can be given for allergic conjunctivitis, and we said it's licensed from age 6. Okay, so 6 years of age for sodium chromoglycates eye drops for allergic conjunctivitis. Typical symptoms are itchy eyes, redness of the eyes, watery eyes. Okay, all right, next question. Which of the following medications is commonly associated with causing a vitamin B12 deficiency after long-term use? Which of the following medications is commonly associated with causing a vitamin B12 deficiency after long-term use? Metformin, yes, metformin can cause vitamin B12 deficiency. So if they give you a question and the patient has symptoms like tiredness, fatigue, or symptoms that has to do with vitamin B12, okay, it could be due to metformin. Okay, which of these antidiabetics could most likely cause abdominal pain? Which of these antidiabetics would most likely cause abdominal pain? Which one causes gastrointestinal disturbances? Metformin, yes, metformin could cause gastrointestinal disturbances. Okay, so abdominal pain is a side effect of metformin. Vitamin B12 deficiency is a side effect of metformin. Okay, and that's why we say if patients do not tolerate metformin, they should be switched from metformin to a modified release preparation if they do not tolerate metformin due to the GI disturbances. Okay, glycoside is a sulfonylurea. Um, Obviously, this can be used. This is a preferred option to longer acting sulfonylureas for patients that are elderly and at risk of falls. Okay, and we've got palglitazone and insulin glargine. All right, next question. Which anti-malarial should be avoided due to the risk of neuropsychiatric effects? Yes, mefloquine. Mefloquine, that's the right answer. Mefloquine should be avoided in patients, um, if possible, due to the risk of neuropsychiatric effects. Okay. And another thing you should remember with mefloquine is its risk of seizures. It can increase a patient's risk of seizures. That's worth remembering as well. Which of the following SSRIs is said to be the safest? Which of this one is preferred because of its tolerance profile? Is it A, B, C, or D? Yes, option D, sertraline. Okay. What's the major risk associated with citalopram? What's the major risk associated with citalopram? What's the major risk? Yes, hyponatremia, but aside hyponatremia, QT prolongation. Yes, that's what I was looking for. So citalopram and escitalopram can cause QT prolongation. And what's the maximum dose? What's the maximum dose of citalopram in elderly? What's the maximum dose of citalopram in elderly patients? 20 milligram. That's correct. Maximum